what are you assessing for, by system to help that patient from having more complications. You should be aware of the physiology, nursing interventions, and, clinical manifestations, collaborative care, and nursing management of the dissections and the aneurysms, pretty much. Okay. So this is showing you a picture of an aneurysm, arterial anatomy. So with that, you have the inner layer, the outer, and the outer layer. So you have the intima, the media, and the adventitious layer. So what is an aneurysm? It's a major disease of the aorta. It can be the abdominal aorta or the thoracic aorta. And basically what you have a buildup of plaque, pretty much. And because that plaque, it sits in some of the beds, what happens is you have a bulging, and with that bulging, if it develops into an aneurysm and it gets bigger, it can burst and they can actually bleed out, and it can lead to an aortic dissection. So an aneurysm is that weak spot in that artery. So that weak spot becomes weaker. If a patient has high blood pressure, it becomes even weaker because you have more pulsations through it. They have a lot of plaque. They exercise a lot. It's getting bigger, and it's going to bulge out and it can burst. So at some point, what they have to do is they monitor it for a period of time. Once it gets up to a certain size, they're going to decide that they need to have surgery. And usually that's around like the 5 to 5.5 area where they decide that patient needs surgery. Because what happens with the aorta? How much blood do we get from our aorta? Most of it. It supplies most of the blood in our body, correct? Mm-hmm. So if you tear that, pretty much you will bleed out. Okay. And most of these occur below the renal arteries. So this is showing you the outpouching that happens normally. You can see the one is a normal aorta, and the other one, because they have an aneurysm, and because those walls are weak, it's starting to bulge, and you have that stretching within it. It can be congenital, either you're born with it, or as with time, because they get weaker, you can just start to develop it. This is pretty much showing you, the same thing in the bulging and everything. All right. So what are some predisposing risk factors? Men are more common to get this. Your smoker, your patient with COPD. The major causes of what I have there in red: smoking and coronary artery disease, or atherosclerotic heart disease, which is pretty much the same thing. Other ones include obesity, a history of stroke, and things like that. But the biggest, major ones are smoking and CAD. So you can have an aneurysm in more than one location, because again, you have a thoracic aneurysm and you have the abdominal aneurysm. The thoracic are again in the thoracic area, closer to your lung area. So when you have those, the symptoms are related to breathing. Because you get the symptoms when that aneurysm starts to push on a major organ. So if it's pushing on the lungs or something, somebody can have difficulty swallowing, difficulty breathing. If it's thoracic, down below, it's like pressing on the kidneys, things along that line. The aorta is larger than 3 centimeters, so once it gets that size, it's considered to be an aneurysm, and the growth rate is unpredictable. But if they start to see it growing, the doctor and nurses will teach you, you need to cut down on this, you need to take your medication, monitor your blood pressure, because the higher your blood pressure is, the more that's beating and the more pressure you're putting on it, so you're making it grow and you're moving to the point where it can burst. So what happens is that dilated aortic wall becomes lined with thrombi that can embolize, and with that you can have like a stroke, an ischemic stroke. So there are different types of aneurysms. If you look at the pictures, the saccular, that's the one where you see it's just a sac pretty much there, all right? You see a sac. With the fusiform, and this is not on the test, just so you know. It's a circular tire-like appearance. The dissecting one is split, and the false is that it's false. And it's false because it's like a pulsating sensation from the beginning, so that's letting you know that it's a false. And obviously, the doctor's going to, look at it, do a test and everything, to see if it's false or what type of aneurysm it actually is. When you talking about the thoracic aneurysms. The saccular is the more common one, and it's more likely to rupture. And as far as the abdominal, the fusiform are the more common types. So your symptoms, again, they vary based on location. Remember, you can have a thoracic or aneurysm or the abdominal one. So again, if you're talking about the thoracic, which is higher in the chest cavity, you would have that dysphagia, difficulty swallowing, depending on where this thing is pressing. If it's growing and it's pressing on that area, you can have on the lungs some dyspnea or some shortness of breath. Pressing on the stomach or the GI penetrating, epigastric pain, abdominal distension. This pain intensifies as it gets bigger and if the aneurysm starts to leak. So here you have a thoracic, God bless you. What are some of the clinical manifestations associated with thoracic aortic aneurysm? A lot of times they're asymptomatic. But the A88 is the one, the abdominal aortic one is the one, and I know I'm skipping around, but that's the one that sometimes a person doesn't know they have. They go in for your routine examination. The doctor will listen, he'll hear a bruit and notice it. Okay, and that's when they, now you have to undergo some lifestyle changes. But, with the thoracic one, it's very common to be asymptomatic, but when you are symptomatic, you have a deep, diffuse chest pain, severe back pain, and why is that? Because you have that decreased blood flow to the coronary arteries. Here, again, if it continues to grow and you have that compression against other vessels, there's a high risk of rupture. Because it's in the lower areas, it can press on the kidneys, and with that, you have a decreased urinary output. If it's in the ascending aorta area, you might have it can actually affect the heart, affect the valve, and you can have some aortic regurgitation. The abdominal aortic aneurysm, your classic manifestations, initially, again, people go in, they don't realize they have it. The doctor examines you, he might hear a bruit, he might press on it a little bit and send you for some tests and realize that you have it. The one thing you do not do if you know a patient has an abdominal aortic aneurysm is press on it, okay? You can listen. If you listen, you will hear a swish, a bruit or anything. If you press on it, you could, rupture, which is not what you want. But when they do start to have pain, they'll tell you it's a low back, navel, abdominal type pain. It's flank pain, it's long lasting, and it's steady. It's not relieved with anything, okay? It is similar to the pain associated with abdominal or back disorders, so that's why sometimes it's hard to diagnose, because sometimes when you have that back pain, I don't care what you take, depending on, arthritis, if you're older or anything, it's hard. That's why you have to do additional tests. But what happens, as I said, when the patient is examined for a routine physical, you go in every year or whatever, you have pain, they do a CT scan and everything, they might do a TEE, that's when they start to notice you have that aneurysm. At that point, they'll figure out what the size is, and they'll tell you what measures to do, usually taking beta blockers, monitoring your exercise, monitoring your blood pressure and everything. But when it's bad, it's palpable. Like you can actually, if it's sticking out a whole lot, you can see it. It's like the blob that has a life of its own. Like you'll see this pulsing sensation, and you'll hear, I don't know, the blob is like a really old movie, but and you'll hear that swooshing, that bruit type thing. When it's abrupt though, like say they don't know it's abrupt, it's a severe pain. They'll tell you it's intense, it's severe. Again, it's still in that lower abdominal back area, and it can radiate to the groin, the legs, and to the back, to the buttocks as well. And that, if it's that sharp, sudden pain, there's a high degree of that it's going to rupture. Additional signs, and these are signs related to inadequate blood flow, angina, hematuria, because you have bleeding into the kidneys, so you have that hematuria, syncope, and then you're going to have blood pressure inequality. So if you take the blood pressure, in the arm, and you would actually take the blood pressure in the lower legs, because you have decreased circulation, they would not be equal. You have blue toe syndrome, and what's that? That the toes actually begin to turn blue because there could be some type of clot in the lower circulation. or anything, they're not getting circulation, so you have the blue toe syndrome. And then you have patchy modeling of the feet and toes, and you can feel a pulse, but it'll be very, very faint, and it might not be, it's not equal, because you know whenever you palpate your feet and pulse, you should be both at the same time, they won't be equal. How do you diagnose this? The same thing as before, the chest x-ray. You might see some abnormal widening of the thoracic cavity if they have a thoracic aneurysm. Abdomen, you might see some calcification within the abdominal aortic walls. EKG, remember they said they feel like they have really, really bad chest pain. So actually you're doing the EKG to rule out the MI. And they might actually draw troponin levels too to rule out an MI. And they know something else is going on. A CT scan is more accurate than anything. Your echo, with this you can have some valve insufficiency, so that's going to tell you how the valves are functioning, and the MRI is useful as well. But if you do have an aneurysm and it does rupture, then you have serious complications. Remember I told you about the retroperitoneal bleeding, and again you'll know that because they'll have bad bruising on their abdominal area, much worse than when a nurse gets a bad heparin injection. You just see all this bruising on the abdominal area. And with that, it needs to be treated right away because that patient can actually bleed out. They're bleeding internally. And they're gonna have that bad back pain, and they're gonna have some ecchymosis in that area as well. They can, have a massive hemorrhage, and if they hemorrhage, what type of shock are they at risk of going into, or are they actually going to? Yeah, hypothermia. Exactly. So the complications are what? As we said, rupture or hemorrhage, vascular insufficiency, emboli, and that's your blue toe syndrome when you have that clot somewhere. So they're not getting adequate circulation all the way down to their feet, and because of that, the toes are turning blue. Yes.
So they will still have that severe back pain, even if it hasn't ruptured yet, right? Because of the pressure?
Yeah.
Okay.
Yeah. Once it ruptures, they don't get out.
So that would be
That's a precipitation. It could be a sudden onset, severe pain, not relief of anything, abrupt. It's about to rupture. Maybe you can do something. Hopefully you can. To it, something called an aneurysmectomy, or there's other things you can do as well. But if it ruptures and you try to, at the point where it gets really, really bad, they're probably going to try to do something, the aneurysmectomy, but there's a low survival rate with aneurysmectomy. It is emergency. And they can bleed out. But as a nurse and collaboratively, our goal is to prevent that aneurysm from rupturing. So again, we're monitoring that patient very closely. Early detection is the best sign. Treatment is imperative. And once it is detected, so again, you're going in for that routine examination. They do the CAT scan or whatever. It's 1 centimeter. Okay, they tell them to come in periodically. They might tell them to come in every, initially 6 months so we can monitor it. If they notice that all of a sudden it's starting to grow, they're going to have you come in much sooner, or until if you notice any changes in the pain, if you're having pain in that area and it's not going away, to come in right away. Get to the point where they have you come in every month, because again, once you get into that 5 to 10 meter area, they're going to plan some type of intervention. So you want to prevent, medically, you want to prevent that aneurysm from getting that larger. How do you do that? You want to maintain a good blood pressure. You want to maintain that systolic blood pressure in the area of, 90 to 120 in that area. Not under 90, obviously, but you want to keep it low so it doesn't grow. Your smaller aneurysms are 1 to 4 in that area. That's okay. Again, when you get in the 5 range, 5.5, they're going to do some type of intervention. So some of the conservative medical therapy is giving them antihypertensives and beta blockers to keep the blood pressure down and to keep the that throbbing sensation, and to keep the patient from working too hard by keeping that blood pressure down. And again, as I said, ultrasound, MRI, CAT scan, they're going to do that every 6 to 12 months initially, and they're going to, if it starts to grow, have you come in a little bit more often. The growth rate is reduced, again, with the beta blockers, your antibiotics, and with statins. Again, this sometimes is an accumulation of the fats, the lipids and everything, so this patient would be on lipid therapy. your, not your clavix, your,
So,
stapes, exactly, your stapes. Treatment though, surgically, I said you have your aneurysmectomy versus the EVAR, which is an open, similar to what they did with the, valves. It's an EVAR, and they go in through the femoral artery. Depending on where it is, that's gonna dictate the procedure for correction. But before they get to that state, again, you need your stable patient to do this. So you wanna make sure that blood pressure is under control. So if they're on the vasodilators, the beta blockers, whatever, is it good? So you wanna reduce it to an area that's good, but not more than 20%. Sometimes they'll be on the nitroglycerins, nitrites, that's gonna help bring that pressure down, the beta blockers, your inhibitors, and you wanna control the fluids and control the pain. Again, they have very, very bad pain. What happens when you're in pain? Your blood pressure goes up. So they might be on morphine or something to help control the pain. If for some reason they do need that aneurysmectomy, they give that the basic, that's the procedure they'll do. It's an emergency procedure for the most part, and it's depending on where that aneurysm is. What they do, they make a cut or an incision in the abdominal area or chest to get access to the aorta and chest. So this is an open procedure, okay? Similar to the cavities being open, this is open where they cut your abdominal cavity open to get in there to see it. Okay, so with that, what do you have? The risk of infection on the womb, and things along that line, the risk of bleeding out. This patient will be on the ICU, similar to cavities again, until they're stable. And then, after a week or so, they might go to a regular room. That hospital stay, as I said, is anywhere from 1 to 7 days, depending on their condition, how they're tolerating, how much pain, and things along that line. Because it is a procedure where you go into the abdominal cavities, again, they're going to have an NG tube because you would need to reduce the pressure in that area, right?
Mm-hmm.
So they will have an NG tube. And that will be in place anywhere from 2 to 3 days, and it's going to give the digestive system a little time to slow down, to rest a little as those tissues and everything start to heal. Now the other one is an endovascular. The EVAR is an endovascular repair, and basically that's a stent procedure. So what they do is they go in, the aneurysm is not removed, but what happens is there's a graft. They go in through the femoral artery and they put a graft around that aneurysm, and by doing that, it encloses it in that area, and that the other blood that's outside is just like sort of reabsorbed. So it's all in that tissue, and now you can have normal circulation through the rest of the remaining tissue. So it's not removed, it's covered with a graft, and it does not, it's not an open procedure. They're going into the femoral artery. So what happens when they put that on, the blood then flows through the graft, preventing expansion of that aneurysm because it's enclosed in that graft. And after a while, because it's enclosed, that aneurysm will start to shrink over time. This is better. The EVAR is better. Why? Similar to the other procedure, a shorter period of time in the hospital, fewer infections, you don't have to, the patient is happier because they get out a lot sooner, those type of things. However, with the aneurysm, they got to stay in that hospital. Like they might be on ICU again anywhere from 1 to 7 days. And this is just showing you what they're doing. They're putting in that stent. There's no need for the abdominal decision. But again, when you're doing the thoracic though, you might need that CABG as well. So it depends on the patient, their condition, and their symptoms. But remember the one thing about stents sometimes they don't last that long. But that's the disadvantage to anybody getting stents. So if you're having that endovascular graft procedure, what are the benefits? They're not knocking you out. They're not putting you under anesthesia. You are sedated, but you're not under anesthesia. You're not going to lose a whole lot of blood because they're not cutting open your chest. They're not cutting open up your abdominal area. The survival rate is better with that. Shortened hospital stay, quicker recovery. The patient's happy because they're getting out sooner. And the insurance company is happy because it's not costing them as much because they're not in a week as opposed to 3 days, okay? But what are your risks? Bleeding. That patient can still bleed. The number one risk is endo leak, and actually that's in the next slide. And endo leak is what? When they put that seal in, it's supposed to be sealed, okay? But if it's not on tight enough, it can leak and you have seepage. So that means that the aneurysm, it's not completely closed in, so it's still leaking out. So it's still bubbling, so to speak. So in a case like that, they actually have to go back in and reseal it, because that seepage can cause problems. With that, you could end up with some emboli or thrombus, obviously. There's a risk of infection. Anytime you do any type of cut, even though it's just a small cut, in the femoral area, there's a risk of infection and hematoma formation in that area. Hemorrhage, graft rupture, bleeding out, so shock again. You can have some ischemia because you're dealing with that lower area, so you can have some bowel blockage or spinal cord occlusion, respiratory compromise. The aneurysm can rupture while you're doing it, and you can actually cut that area. You can make a larger area where it's seeping more, so you actually have an actual aortic dissection, and that's an emergency, and that patient is going to bleed out. So again, you have your open surgery patient, and that's all. Whenever you have open heart surgery, whenever you have any type of procedure, more so open heart surgery or I'm going to say the aneurysmectomy, again, that patient's in ICU. So you want to do a good system assessment of everything. So cardiovascular, what do you want to do? Monitor the vital signs, monitor your Swan-Ganz pressures, make sure the O2 sats are good. Anything related to that, listen to the lungs, make sure your rates are good. You're looking at your rhythms and everything. If you're looking at the respiratory system, how are they breathing? Are they having shortness of breath? Can they tolerate certain procedures? Are they getting infections? So system by system, any patient that's in post-op, you need to evaluate them system by system. If they haven't had a bowel movement, when's the last time they had a bowel movement, GI, all those systems. As far as the vascular grafting patient, they're pretty much not in the ICU. They might be on a step-down unit or on a regular floor, because they're not going to have those major lines, all right? Because other patients are going to have those major lines, probably going to be, this is your sicker patient, you're worried about that incision and everything else. These were the copies I think I had that on. Sorry. So nursing, how do you manage this? You want them to go home, so you want to give them very, very good teaching. You might have to refer them to home care. It's scary depending on what they had done, okay? They just had a major procedure done. If they had open heart on top of this, or if they had the open abdominal, they're worried about going home, somebody care for me, who's gonna help me. Pain management is very, very important. They're gonna gradually increase their activity. You can't do that much, especially if they cut that abdomen. I don't think we realize how much we use our abdomen until it's cut, okay? It hurts. So obviously they can't have any heavy lifting. Again, the abdominal area, you don't want that to burst. And you want to teach them the signs and symptoms of infection to monitor their temperature, monitor them from neurovascular changes in level of consciousness, changes in anything neurologically related to make sure they're still intact. And then wound care indicated, you want to start teaching that to the family or them so they can change it. You're telling them the signs and symptoms of infection, and as I said, no driving or heavy lifting for about 6 to 12 weeks. And this is pretty much the same if they open up their abdominal cavity, chest wall. Either way, they shouldn't drive until after they go for their first post-op appointment. And as far as care, remember, we never removed that first dressing after operation. The surgeon would do that, but what would we monitor it for? Redness, more bleeding. What happens when they come out? You put a circle if they have drainage so you can tell if it's draining more. So remember those type of things when you're caring for this patient. But what do you want? And you're also going to monitor those distal pulses. Why? For circulation, because if you're not getting those pulses anymore, that means that area is closed off, and we're having some issues. That's that whole glucose thing. Okay. So what will be our expected outcomes? A patent arterial graft with good adequate distal perfusion, adequate urine output, no signs of infection, stable cardiopulmonary status, and no neurological deficits. Any questions about aneurysms? So what's important? It's important that you know the nursing care, you know the symptoms, and be familiar with the surgeries. Aortic dissection. And this is pretty much this patient is at risk for bleeding out. So this is showing you exactly what happens, and that's there because they're gonna tell you they have severe back pain. And if you look at that cavity, you see how that cavity is literally, it is dissecting, okay? It is literally separating. So your normal aneurysm would create a balloon. This does not. It splits the arterial walls, making a false channel. And if you have high blood pressure or you're stressed or anything, it is not controlled, that increased blood pressure causes the tear to accelerate. So if you have chronic hypertension or anything, that area is widening and widening and widening. And it's getting to the point where it can dissect. What it is, it's a tear in the inner layer, and then because you have that tear in that inner layer, the other ones are starting to tear as well. So it's creating this false lumen area. As the heart contracts, each systolic pulsation causes a pressure. So if they already have this dissection or it's starting to form, again, if they have high blood pressure and it's formed, there's more pulsating against it, it's dissecting more, so it's becoming more serious. It's cutting off the blood supply to the brain, the abdominal organs, kidneys, spinal cord, and extremities. And they have severe pain. The pain is in the back area, neck, throat, it can be anywhere, but it hurts. They will tell you it's one of the sharp, worst pains they ever had, and it's like a ripping or tearing sensation. It's more gradual and intensifies in comparison of MI, because they'll tell you it feels like an MI initially, but it's not going away. What happens, because they're bleeding internally, you'll see nausea, vomiting, a lot of diaphoresis, shortness of breath, dizziness, faintness, absent or weak pulses. And the symptoms may mimic an MI, so sometimes they're trying to rule out an MI. These are the tests they do, the EKG again to rule out the MI, the chest x-ray, the 3D CAT scan with contrast, and the TEE. But the TEE is only if they're stable. They don't have time. If they're not stable, they don't have time for that TEE. What they're doing with that TEE, they're trying to see if there's any emboli in there, but if they're not stable, they don't have time for it. What are the worst complications? Again, that rupture. If it ruptures, it results in exsanguination, and they're going to die because they're going to bleed out. They can have some hemorrhage in the mediastinal or pleural and abdominal cavities, and it can include the arterial supply to the vital organs. If it truly dissects, or in the process of dissecting, they need immediate interventions. You have to stabilize that patient as best as you can. Obviously, the doctor's going to do everything hemodynamically. You want to reduce that pressure, that blood pressure, because by reducing that blood pressure, you're reducing the stress on the body and the stress on the heart. Okay, and it's not pulsating as much, so it's not tearing as much. And you want to control the pain. Usually, the pain, only thing that might control it is morphine. Okay, obviously they're very, very anxious, and I hurt a lot and everything. So Ativan for the anxiety as well. Some of the things additional things that will stabilize their blood pressure are things like your nitride and your ACE inhibitors. And the nitride is going to help with the blood pressure too, so it's going to help bring that down. Surgically, you can have that, it's an endovascular dissection repair, which is similar to the EVAR, the same thing, they're going to go up and pretty much encase it into that graft and then tie it up nice and tight. This is usually early, if it hasn't actually, it's earlier in the dissection process than later. And this is when drug therapy isn't working anymore. Post-operatively, everything that you do for a post-op patient, you want to monitor them very closely, monitor the pain, monitor the bleeding, monitor for pulses. They should remain on those antihypertensive, because you still want to make sure that it's contained. And if the pain, for some reason, if they go home and that pain returns, and they'll know how that pain is. It's a very unique pain. They have to go straight back to the ER because they need immediate attention. Because the most common cause of death with this is actually rupture, dissection, bleeding out. One of the other complications related to this is a cardiac tamponade, and what is that? That's a severe life-threatening disease. Pretty much the heart is drowning. Okay, it's drowning in its own fluid. So some of the signs and symptoms related to a tamponade, the hypotension, narrow pulse pressure, extended neck veins, muffled heart sounds, and the pulse is paradoxal. So again, your goal is to decrease the blood pressure, keep it down, reduce. You want it to be contracted, but you don't want it to be contracting too much. So how do you do that with the beta blockers, the calcium channel blockers, nitrite, and the ACE inhibitors, and pain for management? Any questions about aortic dissection or anything? Okay, let's do the last case study. This is a lovely 74-year-old woman. She comes to the ER with deep chest pain radiating throughout the chest to the back. She tells you she has a history of smoking, 1 pack a day for the last 20 hours, but she quit 5 years ago. She weighs 112 pounds. So, based on her symptoms, what type of aneurysm do you think she had? Thoracic, right. What are your immediate concerns? I'm sorry?
Breathing.
Freezing? Breathing and it rupturing, right? Rupture. Okay. She has an EKG and it rules out an MI, okay? The chest X-ray is suspicious for thoracic or aneurysm, and she's now scheduled to go to radiology for a CT scan of her chest. Okay, she comes back from the CT scan with the diagnosis of a thoracic aortic aneurysm. It's 5.2. They're probably going to do some type of surgical intervention at this point. The surgery comes in, and she's scheduled for surgery in the next hour. So what do you need to teach her at this point? What do you think you need to teach her if she's going to go in for surgery? Think of pre-op teaching. What do they usually do before you have an operation? What do? They come in, tell her they're probably going to draw some blood, they're going to get informed consent. It's important that they look at the PTI-NRs, coagulation. If she doesn't have an IV in the beginning, they're probably going to send her an IV. And if she has pain, they're going to give her something for pain at that point, correct? I tell her what to expect after the procedure, okay? What I didn't say is post, if you have that EVAR and it's going into the femoral artery, it's the same thing as, because it's not, well, it's invasive only because they went through the femoral. So the care is similar to post-cardiac catheter care. All right, they're in that bed for, like 4 to 6 hours flat because they, again, you don't want them to bleed out, okay? So it's the same thing as post-cardiac cath care with that, okay? So, assessment findings include alert and oriented person and place. She's disoriented at times, so that's important to know because she already has some type of neurological changes. Her blood pressure is 158/98, pulse 92, respiration is 22. She tells you she has pain as 6 on a 0 to 10 scale. She has audible pulses with Doppler. So, what assessment findings concern you at this point and why? Blood pressure, definitely. Anything else? The pain, and she's already disoriented. Right. The daughter comes in. Her daughter is very anxious and has many questions regarding the surgery. But then she has surgery. It goes well. She arrives in the ICU. What are your priorities in monitoring her in the immediate post-op patients? What are your priorities? Vital signs always. Okay.
Level of consciousness.
Neuro. But monitor that blood pressure. That blood pressure has to be low, but you don't want it to go too low. What happens if it goes too low? But that graph can actually close if it's too low. Okay, so if they put a graph on there, which they did in her, okay, you have to have adequate blood flow. It can't be too low. So if it's too low, that you can have some thrombosis within that graph. So you don't want a low pressure. What other priorities? Well, suppose she has suppose she has hypertension. What would you give her? Okay. She would get something anti-hypertensive. What else might she get?
Lazy.
Possibly Lasix. What else do you need to monitor her for though? She just had surgery.
Potassium. Potassium infection.
Pain.
And you want to monitor for fluid overload too? How would you know she had fluid overload?
Urine. You check the urine?
Listen to her lungs. What else?
Iron.
I'm sorry, monitor. Swelling, edema, lung sounds. If she's in the ICU, how would they monitor? Another way they monitor for overhydration.
BUN?
CVP.
Oh,
All right.
CVP.
So what would happen? The CVP would be what?
It's 2 to 6, but if it's over to 6, that means
If she's overhydrated, your CVP would be going up,
High, yeah.
continuously up, and that's the sign of overhydration. She progresses well and is scheduled to be discharged. Her daughter is present and they are ready for discharge instructions. So what are some of your discharge instructions you need to give her?
Come back if she's like experiencing pain again.
Follow up, pain management, medication compliance, nutrition therapy, all those things, probably refer, maybe a social worker refer to home care, possibly an aide, those type of things. All right, we're done. Any questions? I advise you come to surgery, the class on Thursday and look at the PowerPoint. Okay, so we need to look at the PowerPoint.